I'm gonna I'm gonna start recording. Welcome everybody. So I am Ignatius. I am a consultant for NCAPIP on policy. I've had a number of different career paths. I actually started out as a civil rights lawyer, and so a lot of what I'm going to talk about is very legalistic, and I will try to break that down. And I also worked as the policy director for the Asian and Pacific Islander American Health Forum, so really got seeped into health and healthcare policy through that position, and then also have had other positions where I've been involved in advocacy, including helping to create the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders way back in 1999. So what I'm going to do is stretch your minds a little bit, hopefully, of showing all the different ways in which policy and advocacy can be used on a whole range of issues in a whole variety of formats and venues and strategies. And many of these are ones that NCAPIP, the National Council of Asian Pacific Islander Physicians, have used. But obviously our sister organizations like the Health Forum, like the Association of Asian Pacific Community Health Organizations, APCHO, which represents the Asian American, Native Hawaiian, and Pacific Islander serving community health centers. And then there are other organizations that represent our communities, particularly on issues of mental health, on issues of substance abuse, on women's health issues, on LGBT health issues. And so there's lots of intersections and other organizations out there that are doing parallel or overlapping work. And I want to make clear that it's really important for us to work in collaboration with each other, because oftentimes our voices are not necessarily ones that are heard. And so it's really important for us to amplify the Asian American, Native Hawaiian, and Pacific Islander voice as much as we can. So I'm going to start sharing screen. Can folks see that?
Mm-hmm.
Yep.
So we talked a little bit about each of your experiences, and we've already referenced that we have begun this collaboration with APAMSA, which we're really excited about, trying to constantly update on both policy changes, but also resources. So articles that are published that are relevant to Asian American, Native Hawaiian, Pacific Islander health and medicine, data that is published or made available, resource guides that are made available are all really important for us, because you'll see that one of the really important things about policy and advocacy is to make sure that we're evidence-based and data-driven. And oftentimes we're scrambling to find that kind of data that is particularly relevant and speaks to the experiences of Asian Americans, Native Hawaiians, and Pacific Islanders. And so having all this continue to be available is often really, really important for us to be able to make the arguments that we want to make. So if you remember back to your high school civics class, which is probably the last time you've paid attention to this, or if you're an immigrant and had to take the US citizenship test, then you probably had to go through this as well. But it's really important for us to be thinking about our constitutional system of government, in which we really do have three branches of government, and therefore three what I would call targets or subjects of our policy and advocacy. So we have the judicial branch, the Supreme Court, and all the other federal courts in particular. We have the executive branch, the president, but all the cabinet departments, including the Department of Health and Human Services, but lots of other departments that impact on Asian American, Native Hawaiian, and Pacific Islander health. And then what we think of most when we think of policy and advocacy are laws that Congress passes, the Senate and the House of Representatives. And in some ways, that's the least important of the work that we do, that a lot of the work that we do is actually really focused on the executive branch. So in terms of the legislative branch, even though as a nonprofit organization, the National Council of Asian Pacific Islander Physicians is allowed to lobby, and that's one of the things in policy and advocacy that a lot of folks feel like they can't take a position on legislation, but there are ways that you can do that within the boundaries of your nonprofit tax-exempt status. This was an example in which we were actually invited to submit testimony to the House Ways and Means Committee. This was around COVID, and they were holding a hearing on the disproportionate impact of COVID on communities of color. And so we were able to submit this longer, and you can see that we already, with the footnotes, have lots of citations going forward. And so that's just an example. I've also been privileged when I was at the Health Forum to be able to testify before the House of Representatives committee as well. And again, we were invited to do that. What is perhaps less known is that NCAPIP and other organizations has occasionally participated in advocacy with the judicial branch. And so this first case was a case regarding the Deferred Action for Childhood Arrivals, or DACA program. And as many of you know, one of the big breakthroughs was friends, colleagues who I now consider friends, were able to be some of the first DACA recipients to get into medical school, to be admitted into medical school. And now more and more medical schools are admitting DACA students and admitting them into residency programs because they have work authorization, they have temporary immigration status, they're allowed to be here. And so this was challenging that program. And in 2019, NCAPIP joined a brief that was submitted by the Association of American Medical Colleges, the AAMC, in support of the DACA recipients, in support of their continued status. And so we felt it was important to join the AMA and other medical associations in taking that position along with the AAMC. And so we're really happy to do that. And then as Annie talked about, there have been these attacks on affirmative action. And so in June of 2023, when that decision came out, even though NCAPIP didn't take a position in the lawsuit, we did make a statement opposing, denouncing that decision, that cutback in affirmative action by the US Supreme Court in that Harvard case. All right, so let me stop there, see if there's any questions about legislative or judicial advocacy before I go on to the administrative work. And Winston, obviously, feel free to weigh in if you have any comments or observations as well.
I had one quick question. So you said that there are ways to comment just within the scope of being a nonprofit. What are some of the limitations? Is it just like not endorsing specific candidates and political parties?
Right. So the line is that it is prohibited to make a political endorsement of a candidate for elected office, but you can take a position on pieces of legislation. You can take a position on ballot initiatives. And then there are expense limitations on how much money you can spend on those activities. But almost no nonprofit, even the ones that do a lot of lobbying on bills or ballot initiatives, will never reach that limit because it's a pretty generous limit. And the time that it takes to write a letter or to send an email to take that position is minuscule compared to the budgets of most organizations. And so that's really the bright line, that you've got to track those expenses. But you are permitted to oppose or support legislation and ballot initiatives, but you cannot endorse any candidates.
Okay, great. It's very, I think that's what we've all been sort of operating under on from a PAMSA's perspective. But it's really good to just have someone involved in the legal field just say that.
Yes. And there's still a lot of confusion that people say, oh, I can't take a position on that bill. I can't, call my senator. And again, the time that it would take to make that phone call, you've got to record that and document it and report it to the IRS. But at the end of the day, it will never exceed the limits that the IRS creates.
Okay, awesome. Thanks.
All right. So then the bulk of what I'm going to spend my time on is the administrative advocacy with the executive branch. And so we could start with something like the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders, which again, as I said, was created in 1999. And I'm happy to say has lasted through every administration since up to the current administration. Day one inauguration executive order terminated the White House initiative, and it has not been renewed. And so that's really, really unfortunate. And again, it really became an important avenue because it did cross every department and agency across the federal government for the issues of our communities to be heard by all the departments, regardless of what subject matter they had. So whether it was a transportation issue or a housing issue or an education issue, a health issue, there was a place for it to go because this was across the entire federal government. And then we've seen now, in contrast, these executive orders that are actually restricting access to health, in this case, access to transgender care. It will be interesting. This new Make America Healthy Again Commission has a charge of looking at the root causes of chronic diseases for children and trying to develop federal cross-cutting solutions to address those chronic conditions in children. And so that may actually be a really positive thing if they, again, listen to the science and don't veer off into some odd directions in terms of what they think are the causes of some of these chronic conditions. And then we've got the whole array, primarily the Department of Health and Human Services when it comes to health and health care, but all this alphabet soup, and this is a little bit of a test if you all can spell out what the acronyms, who knows what AHRQ means?
Agency for Healthcare Research and Quality.
Yes, excellent. And what do they do?
I think they make a lot of, at least my experience with like them has been like knowing that they do a lot of like clinical practice guidelines. Um,
So yes, they sort of collate. They're kind of the research arm of HHS that is not NIH, which we are familiar with, that do the external grants. They kind of are the internal research arm of the Department of Health and Human Services. So they'll collect things like clinical guidelines. They develop consumer surveys like the CAP survey, the Consumer Assessment of Health Providers and Systems. They will do something called evidence-based reviews. So they do their own process of looking at what is evidence-based in terms of how to treat particular conditions. And
I would think that our medical students would be most familiar with USPSTF, right?
and and that's a collaboration between AHRQ and the CDC. Yes. And those are the preventative clinical guidelines.
Yeah, which is kind of if you go back to the advent of so-called Obamacare, the sausage making was, with regards to USPSTF. I don't know if you recall, but way back then, before the ACA was passed, there was the initial thought of having a committee kind of look at what would be evidence-based and then thusly covered under insurance plans under some rubric of a national health strategy.
Right.
It has since devolved or evolved into USPSTF. And as you know, if you get scored at a B level or higher at USPSTF, it's supposed to become part of a core of preventive services provided by health insurance companies. That's just an example, probably much more detailed than we need to get into. But
But it could be an example that, we've talked about whether or not with the work that NCAPIP has done on um, getting Asian Americans in particular screened for diabetes at an earlier,
yeah,
at a lower BMI,
yes.
that whether or not that's a point of advocacy that we should be making with the U.S. Preventives Task Force.
Yeah.
So,
And I think Sarah probably is familiar with the activity that emanates out of Stanford around uh, screening for gastric cancer, with H. pylori and things like that. Again, it's probably getting into the weeds, but I mean, but having said that, and being a Fed in the past, AHRQ is almost like a second thought with regards to the bureaucracy within DHHS. It probably has the smallest budget of all of these agencies, actually. Maybe Office of Civil Rights is smaller. And then at the end of the day, when Trump gets through with this, we may not even recognize these agencies as they have been in the last few generations, to tell you the truth.
and what's also interesting, and I can't off the top of my head, some of these agencies require Senate confirmation of their administrators or their directors, and some of them don't. And so that also shows how important Congress thinks they are by requiring the director or the administrator to be confirmed by the Senate. And so obviously, um, Robert Kennedy has now been confirmed as the Secretary of Health and Human Services, and now they're working their way through confirming the CDC director, the NIH director, and others as they move through those processes. So each of these agencies within the department issue regulations, issue guidelines. Sometimes, particularly under the Biden administration, they issued something called requests for information, which were just asking the public for comments and perspectives on policy changes that they might have been considering. And so that was a really useful way for NCAPIP and other organizations to weigh in. And then I'll describe sometimes we want to be proactive and not just responsive and reactive to things that they put out, but actually get ahead of it. And I'll show us some of those examples. And so here's a classic comment on the Medicare Quality Payment Program. This was the bread and butter of how physicians were to be paid under the Medicare program. And this was established under the MACRA statute way back in, I think, 2017 or so. And it required various things that physicians had to do, quality improvement activities, data reporting in order to get paid through Medicare. And the kinds of comments that NCAPIP made was making sure that equity, for example, was included in some of the work that they did, that demographic data was collected so that we could stratify their performance by race, ethnicity, by language, by other factors. And so it's been important for us to watch that program and continue to comment on it. Like I said, there have been occasions. These two were from the National Institutes of Health. One was about how to improve research on Asian Americans, Native Hawaiians, and Pacific Islanders, and the other was how to strengthen the inclusion in biomedical research and advance research that addressed health disparities and health equity. And so we weighed in as an organization with comments on those two requests for information. And then as an example of something that was proactive when COVID began, we did this in April 2020, so about a month or two into the pandemic, where it was really important that the data that was being collected included data that was demographic, so we could see where the disparities might be emerging by race, ethnicity, language, as well as other demographic factors. And so we know from the data that ultimately was collected that there was a huge disproportionate impact on Native Hawaiians and Pacific Islanders. And then in the healthcare worker arena, a disproportionate impact of mortality among Filipino nurses. And so if that data had not been collected and disaggregated, we wouldn't have seen those trends. And they would have been masked in a lot of ways by lumping Asians into another category or not having them broken out in that particular way.
One thing I want to point out, Ignatius, if you go back to that last slide, the number 1, which cites the all 6 Office of Management and Budget categories, OMB, as we know, in federal government, actually is an overarching row, bigger than DHHS. So sometimes you have to kind of, as I think Ignatius was introducing, you have to even think beyond anything that's designated, identified as, health and human. It could be really the administrative function of the executive government.
Right. So then we also issued some recommendations on contact tracing as that became really important as testing began. And then finally, one of the things that we did was this call to action to try to organize Asian American, Native Hawaiian, Pacific Islander physicians and other public health leaders as vaccinations became available. So now this was a year later in March of 2021 to try to really call for that equitable distribution of vaccines in our communities. And we know from the experiences of Asian Health Services and others that it was really difficult for early on for people to get to the vaccine sites. And then there was no language capabilities at those sites. And so patients who spoke languages other than English didn't know how to navigate. And ultimately, it was only by giving the vaccines to community health centers like Asian Health Services to actually give directly to administer directly to their patients that then we saw the take up in vaccination rates in our communities. And that kind of experience, I think, has a lot of lessons for us moving forward on other issues. So we saw early on the executive order around gender affirming care. I'm pleased to say that NCAPIP has taken a strong position joining other physician associations, including the AMA and American Association of Family Physicians, the American Academy of Pediatrics, and supporting gender affirming care, including for children and adolescents. And then as Winston alluded to, there are these other departments that we may not be thinking about, the Office of Management and Budget that oversees lots of different processes, including how data is collected. The census is really, really important as a foundation for where a lot of our data comes from. And then obviously as a community that has lots of immigrants and refugees that continue to come to the US in various immigration statuses, then immigration issues at the Department of Homeland Security also become really important. So this was a really important breakthrough in March of 2024. The standards for collecting race and ethnicity across the federal government changed so that we added a Middle Eastern, North African category, and we required the further stratification of the Asian category into 6 subgroups, and the further stratification of the Native Hawaiian and Pacific Islander category into its top 6 subgroups as well. This is one of those policies that I am very fearful about continuing under the UN administration, given its attack on diversity, equity, and inclusion. But for now, it stands as the policy to require this kind of data collection anytime any data is collected. And so NCAPIP has also weighed in on immigration issues. There was a a really awful order around immigrant and refugee policies. We have supported obviously the continued granting of deferred action status to immigrant youth. And then there was this public charge issue that many of us worked on, which is a part of immigration law that says you may not be able to change your status from a temporary status to a permanent status of permanent residence if you've received public benefits. And under the first Trump administration, they proposed expanding that definition of public benefits to things like Medicaid, or any kind of food assistance or housing assistance, which would have disqualified many immigrants from changing their status from that temporary status to a permanent one. And so fortunately, that was held up by the courts and then reversed to its prior policy by the Biden administration. And we expect that we're going to have this fight again under the current administration to try to go back to the policy that it had proposed in 2017. And then I wanted to end by saying, outside of what we might think of as policy and advocacy for the federal government, that there are really important non-governmental organizations that also set policy and standards for particularly healthcare. So the National Committee for Quality Assurance accredits health plans. It recognizes patient-centered medical homes. The Joint Commission is the largest accreditor of hospitals. And then URAC is also an accreditor of both health plans and hospitals as well. And so this just happened yesterday. I saw this. NCQA is proposing aligning its requirements for race and ethnicity stratification of HEDIS measures, which are the most commonly used quality measures in healthcare by health plans and providers, to align with the 2024 changes that would include disaggregation by the top 6 Asian categories and the top 6 Native Hawaiian and Pacific Islander categories. And we have a 1-month window to comment. And so I will be preparing a comment for NCAPIP and would welcome any help in crafting what that comment should be, which is obviously to support that further disaggregation of race and ethnicity by Chinese, Japanese, Korean, by Native Hawaiian, Samoan, et cetera, to be more accurate in reflecting the diversity of our communities. And then I just wanted to call out, there's other opportunities, the National Quality Forum. If you haven't heard about them, set the standards for what quality measures are used in federal government programs through an endorsement process. And then there's another grouping called the Healthcare Payment Learning Action Network, which is bringing primarily health plans and health systems together to work on value-based payment and value-based care. And they have recently really integrated health equity and health equity considerations and strategies into their work. And so there's lots of opportunities to comment on both the endorsement of particular quality measures that may or may not apply to our communities or apply in different ways to our communities. And then obviously to make sure that the equity considerations and value-based payment also take into consideration language, culture, the diversity of our communities, the unique issues from our Pacific Islander jurisdictions that have different immigration statuses and eligibility as well. And then finally, for all of you in medical school and training, there are opportunities to weigh in on requirements for medical education and training through these various bodies that many of you are familiar with, but also through the Accreditation Council for Continuing Medical Education, that goes throughout the entire spectrum of education and training into continuing education as well. And so I'm not going to spend a whole lot of time on this. I just wanted to show this is the kind of base of evidence that I often turn to in developing what we say in terms of our comments, in terms of our responses to these requests for information. We talk a lot about the fact that Asian Americans, when looked in the aggregate, are considered overrepresented or well represented, but that we still have very underrepresented groups within Asian Americans, and certainly Native Hawaiians and Pacific Islanders still remain underrepresented. And that oftentimes Asian American patients, we just did a survey with APAMSA chapters about whether or not there was Asian American, Native Hawaiian, Pacific Islander content taught in medical schools or case examples that referenced our communities. And we really found a sore lack of that kind of curricular content. And that's really, really important to keep raising. That you all as medical students often experience the microaggression and the systemic discrimination and racism, and then that carries on into your experiences when you become part of the healthcare workforce. And so we really want to position anything that we say in these comments in terms of our understanding of racial justice and structural racism, and in particularly how that also plays out with sovereignty issues for Native Hawaiians and Pacific Islanders as well. And then finally, there are other resources. These are guides that the Office of Minority Health put out that Dr. Wong was part of, that I was part of, that was commissioned by the Office of Minority Health, that talked about community, 3 strategies that we always talk about in anything that we say, which is engage the community, disaggregate data, make sure there's language access. And I would add, workforce diversity as the 4th point that we didn't have a guide on. Unfortunately, these have been some of the victims of the purge from the new administration. These are no longer accessible. The webpage now says webpage not found. And so I fortunately have downloaded them, so we can still use them, but we can't link to them at this point. So let me stop there and see if folks have questions.
Can I just say one thing, Ignatius?
Yes.
I don't, your slides didn't include, which was referenced by our APAMSA colleagues on the call today, organizations like the AMA or the American Association of Family Practice or the Academy of Pediatrics. And certainly those are viable venues in which things are being done. And I do think, and Ignatius and I talk about this a lot relative to the work of the forum and the work of the APCHO. I'm always trying to seek the ways that a physician-led organization can uniquely weigh in, as opposed to our sister organizations who also have a deep and knowledgeable bench around, data disaggregation, et cetera. But when physicians in training say, our patients are suffering because of this lack of research or this lack of awareness, it has much more gravitas than, another group saying that.
Exactly. And I see James has joined us. So if you want to briefly introduce yourself. All right.
His mic's not working.
Yep. So welcome. All right. So any questions, comments, that spur any ideas, anything that seemed interesting that you want more information about?
That was super helpful, your presentation. One thing that I was wondering is, like you mentioned, the data purge and a lot of these important resources are no longer available online. So I have heard some talks about some people like collating resources and kind of like putting them on their own websites? To your knowledge, is there like, are these being re-uploaded anywhere? Is there like some centralized place we can go to access them?
Yeah, so I think there's been all kinds of strategies. There's active litigation against some of the taking down of data, particularly the Centers for Disease Control data, and some of the data sets. So for example, they took down all the results of a behavioral risk factor survey of youth, of particularly high school students. So fortunately, researchers have been able to download some of those data sets and sort of hold them temporarily, in the hopes that ultimately they will get restored and be back up and publicly accessible. I think what's going to be more problematic are, because they're particularly targeting diversity, equity, and inclusion and gender affirming care, then any information about those kinds of issues may not be restored. And so again, the three guides that I showed you that talked about approaches for Asian American, Native Hawaiian, and Pacific Islanders communities, again, it's not clear whether they're going to consider that diversity, equity, and inclusion, or whether that's just a community resource guide. But for now, they've gone way overboard in purging a lot of things. There are some things that are interesting that are still up. So I just checked this afternoon. The Centers for Medicare and Medicaid Services has a very bold health equity framework, and it's still up. So
I gotta talk about that with you later.
yes.
One thing I want to say too, and it wasn't, I maybe I'm gonna state the obvious, but as you saw the different slides of, what NCAPIT has done and what we can do in different settings, I think one thing is we have to understand that there's a part of our policy work that is about informing physicians and informing the public. There's a part of the policy work which is basically organizational and kind of mobilizing, if you will, like Rolando SCOTUS and advocating for COVID access. And there's another part around our public face in terms of amplifying the voices of Asian American, Native Hawaiian, Pacific Islander, not just the issues, but the actual physician voices. So just to think about beyond just the content, the functionality of the different ways that we think about policy.
Right. And I would also reference, Winston talked a little bit about this, and Annie talked a little bit about this. We want to also take advantage of the other opportunities that you might all have, so that if NCAPIP takes a position, then we would want APAMSA to also take that position through a resolution if it hasn't already, and then potentially bring that resolution to the AMA and get the AMA to adopt that position. And so again, we can mutually reinforce and align with those kinds of positions. And that I think is also a really useful strategy and a really important role that APAMSA could play as an organization. So you may not have weighed in on integrating equity into value-based care, for example, an issue, something like that, that may not have been raised at the AMA. So is that the kind of thing that we could begin a process of making sure that APAMSA is comfortable with that position, and then having APAMSA also do some advocacy in its role as an organization, a medical student organization, with an organization like the AMA.
Do we end at the top of the hour, Ignatius?
Yes.
Oh, okay.
So other questions, Annie, Kimberly, James, by chat? Sarah?
I don't really have any questions about the content. Just from what you just mentioned, I think it would be really good if we found different avenues for increased collaboration like you propose. I think that just more cross-organizational collaboration will be mutually beneficial, and it'll help us just have, more heads to kind of think on a topic and generate ideas. What type of structure do you think might be feasible for you guys?
So what I would suggest is, I think the the hard part to predict is when these kinds of opportunities come up. We fully expect with this administration that there will be lots of opportunities for us to and need for us to comment and weigh in on various issues. And so I would propose it's more gathering what your interest and availability is. And then as these opportunities come up, like the present one to comment on the National Committee for Quality Assurance HEDIS measure, addition of more stratification of race and ethnicity. Again, usually these things have a time crunch. So we only have a month or less than a month at this point to do that. Winston has another mini project, a writing project for an AMA document that we were asked to do some writing on. And so, Annie, the way I would respond is, if I could get folks emails and then I can sort of share when these opportunities come up, here's the opportunity, here's the deadline, ping me back if you're interested in working on it, and then we can sort of work from there so that not everyone feels like they have to work on everything, but if there's something that is of interest and people have the time, then they can just jump right in.
Yeah, I think
Yeah,
that's great. Oh, was that?
go ahead. Go ahead.
Sorry. Um, yeah, I think that sounds great. Within APAMSA's advocacy branch, we kind of play it like that already, just within our organization. We have a director in advocacy called the Rapid Response Director, and she sort of kind of sounds like what the role is. Whenever something happens and we feel like we need to speak on the subject, she drafts a stance, and we like pretty quickly, I would say like within a few days, do a little peer review within the branch of the rapid response, and we publish it on our website and on our social media. So there's always people who have flexibility, because in medical school, um different times have more availability for people than other times, different years. So there's people available for that sort of work. I think that would work great for us.
Great.
What I was going to add is I think you're absolutely right. And one of the things that I want to be sensitive to is the sporadic nature of medical student life, the nomadic nature of it. And to recognize those limitations as well as sometimes opportunities, but sometimes there's, load times, etc. But the other thing I want to underscore, if as you heard Ignatius talk about the work, not all the policy work is of so-called newsworthy headline kind of stuff. There's a lot of and I think we're going to, deal with some, very dramatic issues in this Trump administration. But at the same time, we also have to recognize there's some foundational stuff that will always need to be paid attention to. You kind of have to sow the ground. So while I don't dismiss the importance of being kind of contemporaneous in terms of newsworthy, I also want to underscore there's important weigh-ins with regards to fundamental issues to advance Asian Pacific Islander health.
Right.
So, I don't want to go into length because I know we're at the top of the hour, but it was mentioned, I think earlier, by Annie around the AMA. I've been squarely in the middle of their journey around looking at healing and race and transformation. And one of the things is I want to make sure that the report that goes to the Board of Delegates has a notable component of understanding the intersection between immigration uh, and um, and race equity and white supremacy. Right now, I don't think it's a strong component of that. Now, that is obviously not newsworthy because only a few eyes are going to see it initially. But on the other hand, it might have long-term implications for with regards to how the AMA takes accountability of its role in terms of being complicit around immigration and anti-immigrant sentiment in terms of how physicians of color are treated in the United States.
Right. And I would just underscore, oftentimes we claim as a victory when we get a sentence added, when we get a mention added in a list of racialized minority groups, that if we're excluded, getting us back onto that list is a victory in and of itself. So I want to respect our time. I appreciate everybody's attention and participation. And so maybe between Victoria and Sarah, if I could ask you to sort of collect the names and emails of people that are interested, and they'll be sort of on my action alert radar, so that when these kinds of opportunities come up, I will issue that call for help. And I'll always be the point person to help coordinate and follow up on specifically what we're asking for.
Yeah, that sounds great.
And if I'm going to be at the APAMSA conference, so I don't think Ignatius is going to be there, but by all means, I can talk to people as part of this work there too.
Thank you both for your time.
All right. And